Ladies and gentlemen, welcome once again to another episode of the Think Clinical podcast. My name is Hamza. Thank you so much for all the support. Please remember to subscribe, like, and share so that when we share content, you'll be among the first to see those. We really do appreciate all you do for us. Today's episode is going to be focused, and it's as I said last week, it's a series, and this is going to be focused on AI in low resource settings. And this is mainly what African hospitals need to know, because when we look at AI, we always think about it in one bucket, but we forget all the constraints that could make it different in different settings, especially in the African context. So today I'm going to highlight some of those, and these are some of the things that you need to know. But if you think about this, right, there's a hospital in rural Kenya, and I'm not going to name it because this story could be about dozens of these type of facilities where a radiologist sees a patient via WhatsApp. And the seriousness of this is that a patient in a clinic which is about 300 kilometers away from Nairobi gets a chest x-ray. And the physician there probably is a new physician who just finished school, is trying to still figure their life out, doesn't have the skill set to properly interpret this x-ray in order to be able to help the patient the right way, has to take a picture of this x-ray with a cell phone and send it to this physician by WhatsApp. Now, the question is this perfect? Is this ISO certified? And the answer obviously is absolutely not. But does it work? Yes, it does. And I have done that in several situations where you take a picture of an x-ray, send it to a more senior colleague or someone because you're far away, just to get their input and be able to help this patient. Now, I tell this story because it is the most honest framing I know for conversation that I want to have today. And when we talk about artificial intelligence in Africa settings, we cannot start with what the technology can do theoretically. We have to start with what the environment actually is, and then we work backwards. And that is how we are going to get it done. My name is Dr. Hamza Asumah, and I welcome you once again to another episode. Before we go anywhere, I need to address something. The word AI has become almost meaningless because it has been applied to everything from simple decision trees to generative large language models to computer vision systems. And if you're a hospital CEO in Ghana or Nigeria or Ethiopia, and someone walks into your boardroom and says, "We have an AI solution for your hospital," that sentence tells you almost nothing about what they actually have. So let me break down the AI landscape into categories that are actually relevant for the African healthcare setting. Category 1. We have the diagnostic AI, which I know is becoming the most acceptable, most widespread, most used, and has a high adoption. And this is the AI applied to clinical interpretation. So you used to read x-rays, you used to read CT scans, you used to read ECGs, pathology slides, skin lesion images. And the category has seen the most rigorous validation research, and some of the tools here are genuinely impressive. So Google's MIA model, Microsoft's AI for healthcare partnerships, all these are very important and have played a very significant role. Now, a 2023 study in the Lancet Digital Health found that Curie AI, which is a tool, an Indian company, chest x-ray AI detection would see tuberculosis or be able to detect tuberculosis in about 93% of cases. Now, and let me put it this way, it has a 93% sensitivity and a 90% specificity in a multi-country study that included African sites, and performance comparable to experienced radiologists in settings where radiologists are severely scarce. It's pretty impressive. So these are some of the things that we need to look at. So that's the first category, which are the diagnostic AI tools. Category 2 are the administrative or operational AI tools, and these are applied to scheduling, they are applied to billing coding, supply chain prediction, staff allocation. This is where the commercial AI market is most active, and where the gap between the pitch and the reality is often the widest for the African setting. So many of these tools are built on assumptions stable internet connectivity, which we don't have in Africa. It's built on the assumption of electronic health record systems, which we don't have in Africa, on reliable data pipelines, which we don't have in Africa. That simply do not exist in many African healthcare facilities. Category 3, patient-facing and community health AI. Chatbots for triage, WhatsApp-based symptoms checkers, SMS-driven medication adherence tools, voice-based health education in local languages. This category is arguably where Africans' leapfrog advantage is strongest, because mobile phone penetration is high even where broadband is low. And because community-based healthcare has always been central in African healthcare systems, this is something that we really need to pay attention to. So these three categories require completely different infrastructure, different implementation strategies, and different risk management approaches. So when someone pitches you an AI, the first question you should ask yourself is, which category are you actually in? That's the first thing. Now, the real infrastructure question that we need to ask, and here is the conversation that does not happen enough in the AI in Africa discourse. AI is hungry. It's hungry for data. It's hungry for compute. It's hungry for connectivity. And the diet it needs to perform all the levels advertised in the marketing materials assumes an infrastructure environment that is radically different from what exists in most African settings. So let me be specific. A diagnostic AI tool that reads chest x-rays requires those x-rays to be in a digital form, but in a large percentage of African hospitals, particularly district hospitals and rural facilities, x-rays are still taken on films. So you cannot feed films into a neutral network. So before you deploy that AI, you need digital x-ray equipment, which means capital expenditure conversation, and which means financing, which means a whole different project. Electronic health records. Every AI tool built for hospital operation assumes that the patient exists in a structured, searchable digital format. The African Scope Health Survey published in 2024 found that fewer than 30% of African public hospitals have functional electronic health record systems, which means the data that AI needs to learn from, optimize against, and generate predictions about does not exist in a usable form for the majority of African healthcare facilities. A 2024 systematic review of Journal of American Informatics Association found that 164 AI implementations studied in low to middle income countries, only 22% have been validated in a specific local context where they are deployed. The majority were tools built on high income country data applied with the assumption they would generalize. So most of the time we are making these decisions without even paying attention to the environment or the landscape in which we are implementing this, and the assumption that they generalize is often wrong. And this matters because an AI system that gives you a false negative on a malaria diagnosis or misclassify a sickle cell crisis as a routine anemia in a setting where a physician cannot easily catch the error is not unhelpful. It's not just unhelpful, it's dangerous. And you have to understand this in the context of healthcare, because any decision you make, life or death situation. And I'm not saying do not use AI. I'm saying do not use AI without asking the hardest questions first. Was a tool trained on data that looks like your patient population? Has it been validated in your specific language or disease context? What happens when the connection drops mid-use? What is your fallback protocol? Who is accountable for when it's wrong? These are some of the things that you should be asking yourself. So where AI actually wins in African healthcare system is what now we need to pay attention to. And having laid out all the honest challenges, let me tell you where AI is generally delivering in Africa right now, because there is real signal in the noise. First, tuberculosis and infectious disease detection. TB kills more people in Africa than almost any other infectious disease, and this is something that we have to be very cognizant about. And it's also notoriously difficult for diagnostic accuracy without any other without laboratory infrastructure or the things that you need to be able to get this done. Now, AI-powered chest X-ray reading tools deployed on tablets with intermittent connectivity have been used in South Africa, they've been used in Kenya, they've been used in Uganda to screen thousands of patients in community settings. The evidence here is strong. This is real, so it's able to help. Second place where AI has been successful is maternal health and obstetric risk prediction. And several organizations have deployed AI-driven risk stratification tools for pregnant women in community health worker programs. A midwife in rural Ghana using a tablet-based tool can input clinical data, blood pressure, fundal height, fetal heart history, and get a risk flag that tells her whether this patient needs to be transferred to a higher level facility immediately. This saves a lot of lives. The third place where AI has been successful, and if you are listening to this as a healthcare leader, is supply chain and pharmaceutical inventory management. This is unglamorous, but enormously high impact. So stockouts of essential medicines are among the leading causes of preventable deaths in Africa. And this is something that has been and has played a very, very important role in getting people into that space. The fourth space where it's been successful is mental health and patient support via mobile. And I want to highlight this one because it's often overlooked. Mental health infrastructure in Africa is profoundly under-resourced, and the continent has fewer than one psychiatrist per million people in some countries. WhatsApp-based and SMS-based mental health support tools, many incorporating simple AI tools for triage and response, have shown a real uptick and real impact in reaching patients who would never access a formal mental health facility in these areas. So this is the fourth one that we need to look at. Now, so what hospital leaders should know or do right now? So what should you actually do if you're a hospital CEO or a clinical director in Africa, and you want to start moving with AI responsibly, let's say in 2016 or moving to 2017? The first thing you need to do is audit your data foundation before you buy any AI product. Do you have the electronic health records? Are they complete? Are they consistently used? If the answer is no, you first have to invest into that first before you start thinking about AI. The second thing you need to do is now to identify the highest paying clinical or operational problem that you want to fix. Not the most exciting problem, the most painful one, and the one that is costing you money, costing you patient life, or consuming your staff's time in ways that are clearly inefficient. AI is the tool there. Step 3 is now to demand local validation evidence. Before any vendor demos, ask the question, where has this tool been validated in an African context? That is one of the most important questions. And then the fourth one will be to start with a pilot. Not an enterprise-wide rollout, a pilot in one department with clear success metrics and a defined evaluation period, and an exit clause if it does not perform. Make sure these are part of the tools that you create and be able to get this done. Here's my honest summary on AI in Africa in 2026. The hype is real, and some of it is earned. There are tools doing genuinely impressive things in the African healthcare settings, and TB detection, maternal health risk stratification, supply chain optimization, mobile mental health support, like I mentioned. These are not future promises, they are current realities, and they are happening. But the gap between the best case and the average implementation is wide, and that gap is filled with failed pilots, wasted budgets, and in some cases clinical decisions made on AI outputs that were never validated for the patient population that they applied to. Your job as a healthcare leader is not to resist AI, and it is not to adopt AI because everyone else is talking about it. Your job is to be disciplined enough to ask the hard questions, humble enough to build the infrastructure before the fancy application, and bold enough to move when the evidence supports it. Africa's leapfrog movement in healthcare technology is real, but the leapfrogging still requires a landing. Make sure you know where you are landing before you jump. This has been another very exciting episode. Thank you for your time. Thank you for all you do for us. Continue to subscribe, like, and share. We'll see you in our next episode.
White coat, black notes, I plan like a surgeon.